Dr. Zaimin, are you ready, Dr.?
Okay, start. Jom.
Dr. Liu pun okay?
Boleh.
Alright, Dr. Eugene, you can start now lah.
Okay, boleh. Good evening to everyone in attendance. Welcome to our College of Physicians weekly webinar. Currently, we are in the month of October, and October is dedicated to the subspecialty of nephrology. Welcome to our second week of our series. Today, our title is topic Anticoagulation Strategies in CKD and ESRD patients. So, it is a great honor for me to introduce our chairperson today. He is none other than Dr. Liu Wenjun. Dr. Liu is the face of nephrology in the state of Johor. He's at present the head of Department of Internal Medicine in Hospital Sultanah Aminah, which is one of the busiest state hospitals in Malaysia, as well as he's holding the position of the state nephrologist of Johor since the year 2018. He has trained many nephrologists over the years, many of which are now making their own mark in the field of nephrology. If there's one thing that I would personally say about Dr. Liu, it would be that he's always readily available for consult any time of the day. And he's always someone who is willing to hold your hand when you encounter difficult situations. So that is why I think he is affectionately known as Papa Liu to many of his trainees and also medical officers in Johor. With that, Dr. Liu, I'll pass the floor to you.
Thank you, Eugene, for your kind words. The Papa is sort of evolving phenomenon, but I will,
Okay, probably aware of it already
will not
anyway.
dwell that too much. But good afternoon to all the participants in the Zoom room. Welcome to the medical webinar on nephrology organized by the College of Physicians. Our speaker today is Dr. Nuzaimin Hadafi Ahmad, who is a colleague and friend from Hospital Pakar Sultanah Fatimah in Muar. He's first graduated from Queen's University of Belfast, Northern Ireland, and then he obtained his Masters of Medicine in UKM. He subsequently pursued and completed the nephrology training with Ministry of Health in 2021. Without delay, let me invite him to speak on a topic that is filled with all sorts of controversies and challenges, entitled Anticoagulation Strategies in CKD or ESKD patients. Thank you, Dr. Nuzaimin.
All right, thank you, Dr. Liu. Or thank you, Papa Liu. So let me share my screen first. All right. Good afternoon, and thank you very much for all the participants. Thank you for the organizing committee for inviting me, and thank you a lot, Dr. Liu, for a kind introduction. So welcome to the month of October, so a month of nephrology. So we had a very interesting talk last week by Prof. Hafiz regarding lupus nephritis and pregnancy. Also a bit controversy and difficult topic, but I think quite relevant, not just us nephrologists, but also to a general physician and also doctors. So this is another controversy topic about anticoagulation in strategies in CKD, especially those patients on a hemodialysis. Let me, this one, right. Okay, so this is our infamous coagulation cascade. So many of you seen this before, and then many of you probably remember it as well. So it's a cascade or the pathway that actually try to prevent any bleeding if actually we had a vessel injury. But some conditions do actually need for us to prevent from the blood to clot, and this is actually where we use the anticoagulant. So as you may aware, so the traditional or the one that actually widely used is still a warfarin, so which actually affected here, and also factor 7. So but then we also have a direct and also indirect anticoagulant. So for the direct anticoagulant, we do have all these new, previously known as a novel, but now we use it as a direct oral anticoagulant. So we have factor 10A inhibitor, and also we have a thrombin inhibitor. So here we do have rivaroxaban, apixaban, and clozapine. And then this is the one that we're familiar, the thrombin is the dabigatran. So all this heparin, low molecular weight heparin, and also a fundoporinox is actually indirect anticoagulant. So it affected the antithrombin 3. So, and then blocking the 2A. So just introduction for the topic today. So anticoagulation, the main reason in patient with CKD and CKD5, still the same with the general population. We're still using the anticoagulation as the management and treatment for acute coronary syndrome. So we do in mechanical heart valve. So this is not going to be discussed today because there's nothing changed. So for those who actually with mechanical heart valve, so the patient need to be on warfarin. There's no change in terms of the guideline because there's no new evidence that actually we can use any other than warfarin for this kind of patient. So jadi today we're not going to discuss about medical heart valve and also the strategy for anticoagulation. So for the venothromboembolism, so this is we're gonna talk a bit about VTE and then which agent to use. And then probably about 50% of my presentation I'm gonna talk about atrial fibrillation and stroke prevention. So this is where the issue arises with regard of the patient with CKD and also patient CKD5 on dialysis. So but before we talk about the anticoagulation part, we need to discuss about problem. So this is actually quite important. So when we talk about a problem, so there's few. So anticoagulation problem number 1. CKD and end-stage patient on hemodialysis do bleed. So there's a few factors contributing toward the pro-hemorrhagic state of in chronic kidney disease. So mainly it's affected your platelet. So there's an alteration in the platelet synthesis, composition and activation, and then can lead to bleed. So the dysfunctional of platelet and vessel wall interaction. So the other one is a reduced platelet aggregation. And then most of the CKD patient are anemia because of either whatever reason, iron deficiency or because of epoetin insufficiency. So, and then we know anemia itself is one of the risk factors for patient to bleed. So before we started patient on anticoagulant, we need to bear this in mind that patient CKD and end stage do bleed. There's a problem number 2. So anticoagulation problem number 2, our CKD and end stage patient on hemodialysis clot. So patient is the virtual triad is affected in patient with the hemodialysis. This increase in terms of the blood viscosity, alteration of the hemodynamic affected the blood flow, and then causing like vessel and tissue injury. So all these things actually happen in patient with CKD. Hence, actually patient with CKD and patient on dialysis tend to clot. So they are at risk. So probably they need anticoagulation for treatment of specific disease or illness. So anticoagulation problem number 3. Since actually we talk about stroke prevention in patient with AF, so CKD and end-stage patient on hemodialysis, AF is common. In end-stage patient, there's a high prevalence of atrial fibrillation compared to general population. It goes as high as 20% versus 1. And then in AF patient, we noted there's a high prevalence of patient with CKD. So the statistics show up to 40 to 50% of a patient with AF do have at one stage of CKD. And then CKD itself is an independent risk factor for stroke. Either patient have or doesn't have atrial fibrillation. And then drop of eGFR by 10 can lead to increase the stroke risk by 7%. So it sounds like these patients are actually at very high risk and probably do need anticoagulation. Anticoagulation problem number 4. So as we know, our patients are complicated. So end-stage patient on hemodialysis, they do receive heparin as part of anticoagulation therapy to prevent clot inside the chamber and also the circuit as high as 3 times per week. And then the dose can go up to 50 units per kilogram as bolus and then maintain with 30 to 20 units per kilogram every hour. They also undergo multiple procedures like hemodialysis patient, they do need cannulation. And then as we know, the CKD also is one of the risk factors for patient to have a cardiovascular disease. So many require antiplatelet therapy on top of the heparin as well. They do also have anemia from multiple causes. So most of them is renal anemia. And then I mentioned earlier, anemia itself is an independent factor for bleeding. So if you decided to start patient on warfarin because you want to prevent stroke in this population, so they already have a multiple of medical appointment. So INR clinic will add on multiple appointment, and probably will lead to a pill burden as well, and also defaulted follow-up. So there's a paper published that the TTR, the therapeutic target range, is generally reported about 50% for those who actually on warfarin. So we need the TTR to be more than 70% for warfarin to work to prevent stroke in AF patient. So if actually we didn't receive this much, or target this much, we're not going to get the benefit of the medication. We're going to get the risk and side effect of the medication, which is in this content is bleeding. So it is a problem. So anticoagulation problem number 5 is the anticoagulation complication itself. So there's a documented and known complication of heparin can induce thrombocytopenia. So in patients receiving heparin for anticoagulation in hemodialysis, they can develop HEAT type 1 and also HEAT type 2. So can increase risk to bleed. So for warfarin, it's documented that it actually can cause skin necrosis. And then warfarin itself can increase in systemic calcification, otherwise known as calciphylaxis. Anticoagulation related nephropathy is reported. So we have patients who started on a anticoagulation that have a progress or rapid decline of the eGFR led to end-stage kidney disease. So problem with the anticoagulation. And then anticoagulation problem number 5, before we decided to start patient on anticoagulant, is the evidence itself is scarce. So I quote this from European Society of Cardiology guideline in 2020 for the management of the atrial fibrillation under subheading of 11.8 regarding atrial fibrillation in chronic kidney disease. So I'm just going to read a bit here. So for the creatinine clearance 15 to 20, the RCT derived data on the effect of warfarin and NOAC are lacking. So this patient were essentially excluded from all the major RCT. And then the evidence for those who actually the eGFR less than 15 or even on dialysis are more limited and to some extent are controversial. So there are no RCT and the observational data question the benefit of oral anticoagulant in this population. So data from observational studies suggest the possible bleeding risk reduction in patients receiving direct oral anticoagulant compared to warfarin, but there's no solid evidence for reduction in embolic event. There's no solid evidence for reduction in embolic event with either NOAC or warfarin itself, as shown in recent systemic review. So there's not much of RCT. Many of them is a observational data, is a retrospective or prospective. So, and then we are being encouraged, or actually we must to practice based on evidence-based medicine. So back to this slide. So anticoagulation in CKD and CKD5 with dialysis. So I mentioned just now about mechanical heart valve. So we're not going to go through for the mechanical heart valve. So, but then for the acute coronary syndrome, so the part of the treatment is anticoagulation. So we see the strategy in patients who have CKD. This is from the Malaysian CPG for the management of non-ST elevation myocardial infarction, non-ST ACS, third edition in 2021. So you don't have to read this. What I want to show, so there's only 2 pages, 1.5 pages from the guideline mentioned about CKD. So under the subheading of 8.3.2. So what I want to show you, there's only one here with actually very good recommendation is 1B. The rest, we don't have any 1A, 1B, 1C, 2A, 2B. We don't have that recommendation. That's why patients with renal impairment were excluded from most of the clinical trial. So we don't have a strong recommendation. Some of them is probably as expert opinion. So in general, heparin for both unfractional heparin and low molecular weight heparin are widely used in ACS. So the bleeding risk of this agent increases with the increasing severity of the baseline of the renal insufficiency. Then dose adjustment are important. Just to highlight, because we do see some of our colleagues or junior treating ACS with fundaparinox. So fondaparinux is contraindicated in severe renal failure with the creatinine clearance less than 20. There are limited clinical data available on the use of the fonda for the treatment of unstable angina, non-STEMI, and even STEMI in the patient with the creatinine clearance between 20 to 30 itself. So this is the adjusted dose. So I quote this also from our CPG. Main use, the normally used anticoagulant in the management of unstable angina, non-STEMI or STEMI. So we do have fondaparinux, enoxaparin, and unfractionated heparin. So duration as your cardiologist or the CPG. So our concern regarding the staging in the CKD, anybody with the eGFR more than 30, for all these three groups, there's no dose adjustment required. For stage 4, so fondaparinux is not recommended if the creatinine clearance already dropped less than 20. And then for the enoxaparin, you need to cut down the dose to daily. There's no dose adjustment for the heparin. And then for creatinine clearance less than 15, fonda is no longer recommended because we don't have any safety data or the effectiveness data. So for the enoxaparin, same with the eGFR 15 and 30. And then heparin, there's no dose adjustment. So the strategies for those CKD and dialysis patient presented with the ACS, this is only the two medication that we can use. All right, so that's for the ACS. For the venothromboembolism, which agent to use? This is from our CPG again, Malaysia CPG of Prevention and Treatment of Venous Thromboembolism. So this was published in 2013, and then we don't have any update for the VTE management since then. Under the subheading of renal impairment, it's not much of recommendation. So here we don't have anything about about a direct oral anticoagulant. So the recommendation regarding management, basically, we have data about tinzaparin. So it's safe to be used up to creatinine clearance of 20 with no dose of adjustment. So unfractionated heparin is recommended in all the patients with creatinine clearance less than 30 with the dose adjustment based on the APTT if we don't have the low molecular weight heparin. Fondaparinux should not be used in patient with renal impairment. So with the eGFR less than 20, this is level A, class A. And then warfarin for INR monitoring is safe in patient with renal failure. So class B recommendation. So there's no DOAC in 2013 recommendation for CKD patient. So do we have any update? This is some paper that I want to share with you regarding the use of DOAC. Published in Thrombosis Research in 2021, so this is quite recent. The title is Using Oral Anticoagulant Among CKD Patient to Prevent Recurrent Venous Thromboembolism. It's a systemic review and meta-analysis from 10 RCT from 2013 to 2018. So this is all RCT. There's few study was included in this meta-analysis. We have Einstein here, the use of rivaroxaban, again enoxaparin and warfarin. So we do have a Hokusai VTE, the use of enoxaparin and followed by endoxaban. And then we have Amplify, the use of apixaban. The one with the dabigatran is here, Remedy, Resonate, and also Recover. So this is for VTE. So this is a dosing for all the DOAC in this trial. So when we talk about the DOAC or the new anticoagulant, two things that we need to consider is the effectiveness of the medication and also the safety. For this trial, among all these 10 RCT, they reclassify all the patients into mild CKD, moderate CKD, and severe CKD based on the eGFR. And then they look at the effectiveness and also the safety. So in the effectiveness, they show there's all in terms of the secondary prevention of the VTE and the treatment favored using of DOAC. And then in terms of safety, for the bleeding part, again, it's a favor to DOAC across all the CKD staging. So what they can conclude from this meta-analysis, DOAC and other anticoagulants, warfarin or the enoxaparin were equally effective in preventing recurrent venous thromboembolism among CKD patients. DOAC has significantly lowered the risk of major and non-major bleeding irrespective of the level of renal impairment. There was no difference in terms of the risk of major bleeding between low molecular weight heparin versus any oral anticoagulant. And then there was no difference in risk of intracranial bleeding between DOACs and warfarin. So at the moment, we don't have any update in terms of the recommendation. And then to use any DOAC other than warfarin, you need to still discuss with the patient regarding pro and benefit, because this is actually the 10 RCT, the number of the patient is not so many, except for the rivaroxaban. They do have about 1,000 patients. Okay, so how about patient on dialysis for the VTE prevention? This is published in, let me see, Jason, in 2022. The topic is apixaban versus warfarin for treatment of venous thromboembolism in patients receiving long-term dialysis. So this is a retrospective cohort study. They do include 12,000 patients, US population on maintenance dialysis. So what they can conclude or find in this paper, apixaban was associated with lower risk of recurrent venous thromboembolism and a major bleeding than warfarin. And then there was no difference in terms of the mortality. So, but for us nephrologists and probably all the others, community should, the goal still to be conduct a RCT. So in patient receiving maintenance dialysis, then testing this apixaban and all other indicated DOAC against warfarin following a diagnosis of VTE before we can say it actually safe to be used in patient receiving hemodialysis, either because of the safety or the effectiveness. So that's about VTE. Anticoagulation in atrial fibrillation, and then for the stroke prevention. So not very long ago, before like 2018, 2017. So when we do ask if patient in stational failure on hemodialysis, so receiving dialysis with heparin during dialysis 3 times per week, and then anemia presented with AF, do we anticoagulate them? So if you was asking this question back in 2018, 2017, the answer usually they will say about the CHAP-VAS score. So we check the CHAP-VAS score, and if the CHAP-VAS score is actually more than 2, so yes, we do anticoagulate them. But I think nephrologists previously also didn't treat the atrial fibrillation as for stroke prevention in dialysis population. But then let we see anything new since 2018 until now. So a few questions and also a few things that I need to consider before we decided is a patient on hemodialysis or CKD should receive anticoagulation for stroke prevention or not. So one of it is, should we anticoagulate end-stage patient with AF? Thing that we need to know, does AF itself increase the risk of stroke in dialysis population or in CKD patient? Quite old paper, but published in 2012, Zimmerman et al. Write a systemic review and meta-analysis of incident, prevalence, and outcome of atrial fibrillation in patient on dialysis. What they found in this meta-analysis, the prevalence of AF was about 11.6%. The overall incidence of stroke in this patient about 2.7 per 100 patient years. So the incidence and the prevalence of AF in end-stage patient are higher than in general population. And they conclude it's actually associated with an increased risk of stroke and mortality. So here they said AF do associated with stroke in patient on hemodialysis. But in 2015, published in Stroke and the American Heart Association, Finlay et al. Write a risk factor of ischemic stroke and subsequent outcome in patients receiving hemodialysis. So they study about 1,382 hemodialysis patients. So they found the prevalence of AF was 21.2%. But they said the AF was associated with mortality, but for this population, they were not increased stroke in this cohort of study. So Finlay et al. Said AF doesn't associated or not associated with stroke in patient receiving hemodialysis. They do have all other risk factor, but then in this cohort, they said AF is not associated. So the data is conflicting. So some paper do say yes, AF do cause stroke in patient receiving hemodialysis, but some others said it's no. So conflicting data. So the thing that we need to ask also, does anticoagulation prevent stroke in CKD and end-stage renal patient receiving hemodialysis? This is the one who have AF. This is old paper from 2016, published in CHEST, stroke, major bleeding and mortality outcome in warfarin user with AF and chronic kidney disease. This is a meta-analysis of observational studies. So 2016, the DOAC still cannot be used in patient with the lower EGFR. So they only can use they only can use as approved. So EGFR have to be more than 30. So basically, all these patients are actually on warfarin. Sorry, the slide is not very clear. So this is a meta-analysis of 13 papers. So there's 11 cohort, 6 is actually retrospective and 5 is prospective study. So including 11,000 warfarin user and 48,500 patients. So what they found in this meta-analysis, warfarin for AF prevents stroke in CKD, not on dialysis, but in end-stage renal patient on hemodialysis, it doesn't prevent stroke. So as you can see here in this result. So in BMC nephrology 2016 as well, warfarin use and stroke bleeding and mortality risk in patient with end-stage renal disease and atrial fibrillation. So a systemic review and meta-analysis. So again, in this study, so from 2010 to 2014, so there's a 56,000 end-stage patient from 20 observational and cohort study. Anticoagulation for stroke prevention in dialysis patient, there's no benefit for any type of stroke prevention. And then it's same with all this meta-analysis published here in Gang Liu et al. Medicine 2015, Van der Merch in AMJ 2017, and also Radawa, the recent one in JAMA 2020. So what they can see, the bleeding is higher risk, and then it doesn't prevent stroke. The risk of the hemorrhagic stroke is even higher. They do some paper who actually say is do prevent stroke, but again, the data is conflicting. So for the warfarin for stroke prevention, some studies do say yes, but some studies say no. Generally, it increased risk of bleeding. So here is a hemorrhagic stroke. All this paper from 2020 and below are all retrospective systemic review. So none actually was RCT. So there's 2 ongoing RCT for the treatment for the stroke prevention using warfarin versus no warfarin. So this one we're still waiting for the result, expected to finish by 2024 and 25. So it's an XDL and also done what? So probably we can have an update soon. So for patient who actually, like I said earlier, so the anticoagulation doesn't prevent stroke in end-stage patient, but they do have some benefit in patient CKD who doesn't who does not on dialysis yet. So for the creatinine clearance, the strategies. So if the creatinine clearance is more than 50, so you can follow all the established guideline or the recommendation. Either you want to use the warfarin or any other oral anticoagulant. So the recommendation for the dose adjustment based on the creatinine clearance as stated here, this is proposed algorithm by the American College of Cardiology. So based on the EGFR as well. So there's a change in terms of the punya dosing, following the drop of the EGFR. So CKD non-dialysis will benefit from anticoagulation therapy for stroke prevention, choice and dosing for anticoagulation as proposed by ACC. So anything new in terms of choosing the anticoagulant? So there's few people who that actually strike me as a nephrologist, because initially I said about the problem with the anticoagulation. So one of it is warfarin-induced calcific uremic arteriolopathy or calciphylaxis. The other one is anticoagulation-associated nephropathy, which can cause the range of our EGFR, can cause the EGFR decline and also toward end-stage renal failure. This is antenna. So if you decided to counsel patient for stroke prevention in CKD with AF, and then you discuss regarding the choice of anticoagulant, published in the International Journal of Cardiology. This is paper from 2022. So in Elsevier, they say about renal decline in patient with non-valvular AF treated with rivaroxaban, warfarin. This is a population-based study from the United Kingdom. So basically from this cohort, most of them actually have a normal EGFR or EGFR more than 50. So what they see here about the renal decline. So renal decline here, they define as the doubling of the serum creatinine, more than 30% decline of the EGFR, and then progression of the end-stage renal failure. The number of events was significant in terms of the use of warfarin compared to rivaroxaban. So what they want to highlight in this paper, patient with non-valvular AF preserve renal function at baseline and treated with rivaroxaban has markedly reduced risk and rate of renal decline compared for those who treated with warfarin. Sounds to me like there's a property of a CKD retardation based from this antenna cohort trial. So at the moment, still ongoing about the use of rivaroxaban in terms of CKD retardation. Name is Zarino. So the long name is a real-world prospective observational study to compare the rivaroxaban versus vitamin K antagonist treatment in patient with non-valvular AF in advanced kidney disease patient. So this is a prospective. They look at the CKD patient and then treated with a rivaroxaban. So the final data of Zareno already presented in ACC, but apparently they decided to continue the paper. So overall, from the 706 patients from both groups were included in the rivaroxaban and warfarin group. And then what they found in this prelim, rivaroxaban associated with significant reduction in adverse kidney outcome and all-cause mortality. And then there's no significant difference were observed between groups for the composite net clinical benefit. So I'm looking forward. So probably they can publish the result by 2024 or 2025. All right. Compared to warfarin, DOAC effective. So publish this one in the Nephrol 2020. So they look at the apixaban versus no anticoagulation in patient undergo long-term dialysis with incident of atrial fibrillation. So the initial paper, they show that warfarin doesn't prevent stroke in patient with AF. So now they want to see if actually DOAC can prevent stroke in dialysis patient with AF. So this is published in 2020. So if you're wondering, apixaban can be used in patients with the end-stage renal failure because they have this FDA approval to be used with the EGFR less than 15 or even on dialysis based on the safety data, based on the pharmacokinetic data. So they don't have any safety trial to say it's actually quite safe. So what they found in this population, so this is apixaban versus non-treatment. They're using a standard dose, apixaban 5 mg twice daily versus non-treatment, and also reduced dose apixaban 2.5 mg daily versus no-treatment. So in the standard dose apixaban 5 mg twice daily versus no treatment, so in terms of ischemic stroke prevention, they see the incident is lesser in apixaban group. So 3.5 versus 3.4 versus 4.8. But then when they look at the clinically important bleeding, if you can see here, the incidence of bleeding in apixaban, in the standard dose of apixaban are very high compared to the non-treatment, right? How about the reduced dose of apixaban? Sorry, what I want to highlight is actually it does work if you say it's try to prevent stroke compared to non-treatment, but then it's come with a very high risk of bleeding. So how about the reduced dose apixaban 2.5 milligram versus no treatment? So in terms of ischemic stroke, you give 2.5 milligram to patient with AF and dialysis, and then this one without any treatment, the incidence is the same. So without any treatment, the risk of stroke also about 4.7. If you give also, the incidence also is about 4.5. But then in terms of bleeding, it's also about the same. So 2.5 milligram doesn't add on any extra risk of bleeding. So on top of the if the patient was already was not on treatment. So what they found in this apixaban, is it safe to use in patient with maintenance dialysis? Incident higher or incident are higher with the standard dose. So, but not with the reduced dose, but then with the reduced dose from this cohort of patient also doesn't prevent any stroke. So the incident of stroke is still about the same if actually patient receiving treatment or not. So if you want to prevent, you probably need the dose of 5 milligram, but it will come with the risk of bleeding, very high of bleeding. Sorry, not risk of bleeding. So any other, this is oral anticoagulation for patient with atrial fibrillation on long-term dialysis, quite recent, published in the Journal of the American College of Cardiology in 2022 by Kuno et al. It's a retrospective study, so looking at 16 studies involving almost 71,000 patients. So what they found, oral anticoagulant were not associated with the reduced risk of thromboembolism. So it doesn't prevent stroke. Patients who receive apixaban 5 milligram twice daily had significantly lower risk of mortality. So they look at the mortality, not at the stroke. And then the apixaban 2.5 milligram twice daily versus warfarin and no anticoagulant. The 5 milligram in terms of mortality. So warfarin, dabigatran, rivaroxaban were associated with significant higher bleeding risk compared to apixaban with no anticoagulant. And then the benefit to risk ratio of oral anticoagulant in patient with AF on long-term dialysis warrant validation in randomized clinical trial. So we cannot really say from these retrospective studies, there's more benefit to give OAC in patient with AF. So still warranted for RCT. So it does effective if I want to answer this question. But the dose that you need is very high and then will come with a very high risk of bleeding. So compared to warfarin. So compared to warfarin, doxif. So published in Internal Medicine, meta-analysis in 2019 about the benefit and harm of oral anticoagulant therapy in CKD, a systemic review and meta-analysis. So it's look at 45 trial involving 34,000 patients. There's 8 trial with 685 end-stage patients and 37 trial do have patient with the eGFR with 15 to 60. So benefit of the oral anticoagulant with CKD. So we can see there's a benefit in a patient without dialysis, but then not in the end-stage renal disease patient, and also in patient with the advanced CKD. This is because of the small number as well. So basically it's safe in CKD, but not in patient advanced CKD and also patient on hemodialysis. So apixaban dosing pattern versus warfarin in patient with non-valvular AF receiving dialysis. Again, it's a retrospective cohort study. So Wetmore et al. Looking at a 17,500 patient with AF and then patient receiving dialysis represented in US renal data. They took the data from 2013 to 2018 who had AF and were treated with apixaban or warfarin. So they label as a concordant. This is following the dose 5 milligram and 2.5 milligram according to the 3 3 level of a apixaban, and then most of them using like below level concordant, they just reduce the dose regardless of the EGFR age or the weight. So what they found, apixaban is less bleeding than warfarin. So those who are actually using the standard dose versus warfarin, they have a lower mortality but doesn't prevent stroke. And then for those concordant versus below concordant, those who are actually using the standard level versus those who actually doesn't use the standard level, they found actually the bleeding risks are similar. So they say as a similar risk as a warfarin. How about the effectiveness and safety of rivaroxaban versus warfarin in patient with the non-valvular AF? So from Coleman et al. In 2019, looking at 1,896 rivaroxaban and 4,000 warfarin user. So 88 population of patients are stage 5 CKD or undergoing hemodialysis. So this is using the rivaroxaban 10 milligram. They said it did not significantly reduce stroke or systemic embolism. What they see is actually reduction in the major bleeding risk compared to warfarin. We do have few RCT randomized control trial for the use of DOAC versus warfarin for the stroke prevention in patient ESKD on receiving hemodialysis. So, but if you notice here, the number is very small. So there's a renal AF with the number of patients is 154. When they divide it into 2 arms, there's going to be about like 80 patients in each arm. So same in D. Vrace et al. Looking at the warfarin and rivaroxaban 10 milligram versus the rivaroxaban plus vitamin K2. And also in the Axadia, AFNET, the number is very small, it's 97. So for RCT, all these numbers are actually very small. So what they found in this RCT from the renal AF, the stroke and the bleeding are similar. What they found in the DVRES et al., the VKA, the warfarin have more bleeding with poorer CV outcome. And then in the Axadia, they found the stroke and bleeding are similar, but trend toward the apixaban, more efficacy and safety. But basically what we can conclude from all these 3 RCT, the hemorrhagic risk is actually higher if we compare to the stroke prevention benefit. So you probably don't have ischemic stroke, but then you probably have a hemorrhagic stroke if we decided to treat based on this RCT. But we are waiting for this one ongoing RCT. Is safe. So they're looking at the warfarin versus apixaban. Again, the number is very small, but we are still waiting for the data to see if actually the in keeping with the previous RCT or not. So finishing my presentation, so about anticoagulation strategy for stroke prevention in end-stage kidney disease patient with AF. Summarized in this very good illustration graph. So if your patient is CKD with the EGFR above 30, so the decision to anticoagulate based on the current clinical guideline and randomized control trial derives as a statement with direct oral anticoagulant favored. So there's not much of discussion. I think this is being discussed heavily and extensively for the past like few years. So I do agree for those who actually CKD non-dialysis, if they have AF, they still will benefit from the stroke prevention, because once they got stroke, so they will affected the quality of life, and later when they need dialysis, it's going to be a bit difficult to discuss as well. So to dialyze patient with stroke. For the EGFR 15 to 30, well, the data is still scarce and we don't have a very good RCT. So anticoagulant strategy are only after careful consideration of benefit and harm. So, and also discussion with the evidence that we have, and with all the input, and then discussion with the family member as well. So for the EGFR less than 15 and hemodialysis, basically there's no RCT-based evidence to support the oral anticoagulant therapy. So does the individual circumstances and clinician and patient preference favor oral anticoagulant? So this is the need that we discuss. So you can consider non-pharmacological treatment method like left atrial appendage and occlusion therapy or no therapy. So this is we can consult with our EPS colleague. So and if you decided for treatment, registry evidence favor DOAC over vitamin or over warfarin for both efficacy and safety. So if vascular calcification or calciphylaxis or glomerular hemorrhage are concerned, then we need to avoid warfarin. And then use appropriate, usually labeled dose of oral anticoagulant. So here they are talking about warfarin now. Over DOAC over warfarin. So again, the discussion is very important. You need to discuss with the patient and also the family member as well. So for the EGFR less than 15, so this is from the recommendation. Basically, the use of DOAC, even warfarin was not actually discussed for the lower EGFR or dialysis patient. If you see at the ESC, KDIGO, EHRA, so for the American Heart Association and CHEST, they do mention about warfarin with the adjusted dose of about 2 to 3, and then aim for the TTR more than 70%. Other than that, the use of any other oral anticoagulation was not recommended. So take-home message. So among patients with CKD, there's no progressively increased risk of both ischemic stroke and hemorrhages as renal function decline, complicating the decision to initiate anticoagulation. So no definitive clinical guideline derived from randomized control trial exists to aid clinical decision making, and the findings from all data are conflicting. The limited available data suggests that diaryl oral anticoagulant should generally be favored over vitamin K antagonists in view of their probable increased safety and efficacy of CKD with lower risk of vascular calcification and anticoagulation associated nephropathy. So FDA approves the reduced dose of apixaban and doxaban and rivaroxaban. Then recently also approved the use of a specific lower dose dabigatran, but this is all based solely on the pharmacokinetic data. So we don't have any real safety data to use all these agents in patients with CKD, especially those with on dialysis. So what KDIGO recommendation? There's insufficient high quality evidence to recommend warfarin for prevention of stroke in CKD stage 5 with AF. A bit update in 2019 that I mentioned earlier. They said there was a soft recommendation for using anticoagulation with either warfarin or apixaban with the caveat further study is still warranted. So until dedicated RCT are completed to define optimal management, clinical decision making should be informed by the limited data available, which necessitate the individualization and physician-patient collaboration and discussion. So you need to discuss the risk and benefit of anticoagulation. If anticoagulation is not initiated, the viability of non-pharmacological treatments such as left atrial appendage occlusion may be considered, or whether in fact no therapy is the best choice for the individual patient. Right. Thank you. Dr. Liu, you mute.
Thank you, Dr. Nuzaimin.
All right.
Can you hear me? For
Yes.
bringing us through this jungle of evidence. And actually, as it seems, but unfortunately, that's all we have to base our practice upon. Is that clear? Is my voice clear to you?
Yes.
Okay. So I must say that in clinical practice, trying to start someone with oral anticoagulant is a big struggle because there are, if you look at the MAS score, I think nearly 80% of them on dialysis will fulfill that criteria of more than 2. And if they do have AF, the risk of them running into trouble using whatever agent that you may choose is also a challenging one. And most of the patients that once you explain, they will shy away they would just maintain status quo and not dare to take up that risk. But certainly, it's individualized therapy that you are going to propose. So I'm looking at the chat, and somehow there is no question so far from the audience in the Zoom room.
Excellent.
I'm not sure whether they're so clear, crystal clear with the confusion that they need to have more time to digest all sorts of evidence here. But certainly it's not a clear-cut field to advocate A, B, or C, and different guidelines will shine different light, but we do need more evidence on that.
Great.
Any comments from any expert within the visible 5 parties here? No? All right.
Dr. Liu and
If-
Dr. Nuzaimin, just one question. I'm not an expert, definitely. Just a question coming from a generalist, more of an acute management per se. I think the topic over the past 40 minutes was more of a chronic anticoagulation strategies for certain indications. But usually as generally, sometimes when we encounter patients, with AKI or someone who requires acute hemodialysis, generally we more often than not tend to put in femoral catheters. And sometimes, unfortunately, we do run into the complication of, the patient developing a unilateral swelling at that same site, which is ultimately later confirmed to be a VTE of the lower limb. Are there any comments on how would you negotiate that acute scenario, whether just to pull out the catheter and observe, or, keep the catheter and start anticoagulation, or, any thoughts on that?
So thank you. It's very common actually. So
Yeah.
femoral catheter actually catheter induced. So this is actually we consider as a provoked deep vein thrombosis. The management, yes, you since actually it's a provoke, I do remove the catheter. So we do remove the catheter and then we do start the patient on anticoagulant. So, and then we're still going to continue the anticoagulant because it's a provoke as per recommendation, and then continue for the 3 months duration. So decision for the oral anticoagulant after that, well, if actually warfarin is really difficult, I do last time practice discharging patient on a injection, but then this is very costly and patient going to be difficult to come to the hospital. So at one point, you still have to start a patient on anticoagulation. And for this patient, we have to start a patient on warfarin. If you said it's AKI, so you can monitor the EGFR. So once the EGFR, if actually AKI recovered, so you still can titrate, or you can change the anticoagulant based on the EGFR. So if actually back to baseline or normalized EGFR more than 30, you can choose the oral anticoagulant based on direct oral anticoagulant. Other than that, probably I still can continue with warfarin. So, but then the practice is actually we do remove. Otherwise, the deep vein thrombosis is going to be worsened. The swelling going to be worsened.
Okay, so you will remove and actually treat with anticoagulation.
Yeah.
Okay, sure. Thanks.
Dr. Nuzaimin, there is a question in the chat room that asks about what's your view on hemodialysis via fistula on anticoagulant? Is there any risk of prolonged bleeding at the fistula site?
What your view? Oh yeah. So okay. So I assume this patient was on anticoagulation for probably really indicated what you call it? Indicated to have anticoagulation. So yes, oh, so if your patient on anticoagulation, even your patient on a double antiplatelet, they do have a risk of prolonged bleeding. So especially if the patient already on warfarin. So basically, if patient already on anticoagulant, probably for example, like our patient just now who developed DVT, and then we still have to start patient on warfarin. So this patient on anticoagulant, and then patient still need hemodialysis via the punya fistula. The strategies probably we still need to cut down the heparin. Usually I don't straight away off the heparin inside the dialysis circuit. We're gonna cut down into type. So probably the loading dose gonna be a bit lower, and then maintenance even lower. And then observe is actually in the increased risk of bleeding. So usually after they remove the cannulation, they do compression. If the patient reported to have like bleeding event at home, probably the next dialysis session we're gonna off the heparin inside the dialysis. This usually we can observe even in the hospital. If you ask about the risk, yes, they do have the risk of prolonged bleeding time if the patient on anticoagulant using the fistula. But then, yeah, you cannot off the anticoagulant because of there's the indication for that, right? You have to look at the risk. If the bleeding is severe, probably anticoagulation is contraindicated already. Dr. Lee, you want to add?
Actually, for those who are on warfarin, for example, if they have a heart valve and they are on warfarin and they are undergoing dialysis with hemo, I will not use heparin, because if their INR is in therapeutic range, then by right it will maintain the circuit patency. So I will watch the prolonged bleeding episodes as per the risks involved with anticoagulant, but certainly I will not use heparin. But if they are on the NOAC, then they will be justified if you want to use, but on a lower dose, and watch for complications and tailor-make as per needed.
Yeah.
Okay. I do not see any more questions in the chat room. So perhaps we can draw the session to a close, and I'll hand this time back to Dr. Eugene. Thank you.
Thanks, Dr. Liu. Thank you, Dr. Nuzaimin, for the very enlightening talk. And thank you to everyone in attendance for giving us support today. We will see you all next week for our third session in the month of nephrology. So thank you and have a good evening, everyone.
Thank you.
Thanks,
Bye.
Dr. Liu. Thanks, Dr. Min. See you.
Bye-bye.
Bye-bye. Thanks, Afiq.
Dr. Eugene.